Good morning, students. I shall be taking you through the pain and pleasure of pathology day in and day out. It is better to understand a little than to misunderstand a lot. A brilliant saying of Robbins and a favorite quotation that I have borne in mind as a student. Always the terminologies are important. Infective endocarditis. Earlier, this was called bacterial endocarditis. But over the decades, people have identified that it is not only due to bacteria, but viruses, fungi, and whatnot, and hence the term infective endocarditis. So we can define it as an infection and colonization of the heart valves and the endocardium. Heart valves and the endocardium. Why am I mentioning two places? You people will be seeing. Predisposing conditions, a very important subheading, both clinically as well as pathologically. Patients who have got congenital heart disease, previously who have suffered from rheumatic heart disease, who are on prosthetic valves, infection elsewhere in the body, cutaneous or bone, septicemia, having caries tooth, or through normal oral commensals and osteomyelitis are all prone to have a risk of infective endocarditis. And there is a box here for us, the intravenous drug abuse. Sharing the needle can pave way for infection to the right side of the heart. Hence, the tricuspid and the pulmonary valves are more commonly affected than the rest. Etiology. Name these, you find that most of the infections are covered. Streptococcus, Staphylococcus, E. coli, and in hospital bedridden patients, Pseudomonas aeruginosa. These are all the common organisms. As I had mentioned earlier, there can be fungal infections also. But this is not the list. Something that again I thought will be of great interest to us. Never try to understand things in life which you cannot. What am I trying to say? It is easier to mug up. So mug up things which we cannot understand. Why am I saying something like this? Absolutely no logic, but then it is important. As a group, H for Haemophilus parainfluenzae, A for Actinobacillus actinomycetum committens, C for Cardiobacterium hominis, E for Echinella corrodens, K for Kingella kingae. So groups of bacteria, kindly write this, you will score. Clinically, the endocarditis is divided into two types, an acute endocarditis and a subacute endocarditis. Robbins gives it, so also do Davidson and Harrison of medicine. In acute endocarditis, you find that there is no predisposing lesion. The patient is otherwise well built, but the organism is highly aggressive and it produces bulky vegetations. Sometimes it can cause perforation of the valve leaflet and the infection itself is poorly controlled. An acute infection. Subacute endocarditis, on the contrary, it occurs in patients with predisposing cardiac lesions. The organism is not as virulent as acute. The vegetations are smaller but much larger than the rheumatic heart disease, etc. They are less common and they can be controlled with appropriate antibiotics. So it can be divided into two, acute and subacute. When we talk about the infective endocarditis, there are two types of lesions. One will be the cardiac, the other will be the extracardiac lesions. Vegetations, which can be endocardial or valvular. And surrounding the artificial valves, there can be a ring abscess. An abscess is formed surrounding the valve, as a result of which it can be displaced from its original site. Acute inflammation, when it is being controlled, can be converted to chronic, and just like healing of any wound, there will be fibrosis or calcification. Fibrosis or calcification. If that is difficult, please remember this one. It is easier. The vegetations are bulky. Look at this one. They are large and they are composed of fibrin. There will be organisms within. Areas of necrosis is present. And they occur in the direction of blood flow. This is the upper surface of the valve. So obviously in the upper surface, in the direction of blood flow, they are found. They can overgrow the valvular surface and they tend to hang over. Sometimes they can be present in the myocardium. This is the valve and they can be present in the myocardium. When is it? Whenever the patient has got a septal defect, there will be a jet-like force. A jet-like force that comes, impinges on the endometrium, it causes a damage, and then there can be an infective endocarditis. There can be a rupture of the caudate tendineae. As we had mentioned earlier, there can be production of ring abscesses, particularly in artificial valves. And whenever there is an acute infection in the heart, there can be an acute pericarditis as well. So these are the cardiac lesions. I repeat once again, deliberately, bulky and friable, composed of fibrin, areas of necrosis, occur in the direction of blood flow. They can overgrow the valvular surface, occur in the myocardium due to septal defects, rupture of the caudate tendineae, ring abscesses, and acute pericarditis can all occur. And whenever I say cardiac, there has to be extracardiac, obviously. And outside the heart, we can have embolization. The vegetations can get fragmented, get lodged anywhere in the body, leading to septic emboli. There can be abscess formation in any organ of the body, the kidney, the bone, the brain, etc. Apart from these, there can be, please remember these, the subungual splinter hemorrhages, lesions on the palms and soles called the Janeway lesions, subcutaneous nodules called the Osler's nodes, and areas of retinal hemorrhage called R.A.T.S spots. For students who cannot visualize what I am saying, kindly see this. Infective endocarditis, the extracardiac manifestations, splinter hemorrhages, subcutaneous nodules. Subcutaneous nodules called Osler's nodes. Then there can be the R.A.T.S spots, areas of hemorrhage within the retina. This can be viewed by an ophthalmoscope. And Janeway lesions in the subcutaneous regions. These are all the lesions which can be found. Just like your rheumatic heart disease, where you have got the major and the minor criteria, Jones criteria. Here you find there is no Joan over here, but be the Joan of Arc, that is a mnemonic. So it is a Duke's classification. It is a Duke's classification in which you have got major criteria, wherein there will be a positive blood culture, or there can be an echocardiographic evidence of vegetation. Duke's classification, two major criteria are there. The others are minor. Janeway lesions, Osler's nodes, Aneurysm, mycotic aneurysm due to infections. Nephritis, inflammation of the kidney. And the other features include fever, arterial emboli, red spots in the eye, and culture positivity without meeting the major criteria. So these are all the list of minor criteria to major criteria. Whenever you have got both the major, it is indicative of infective endocarditis. Or when there is one major and three minor, you call it as infective endocarditis alone. Sometimes these are not there, but five minor criteria alone, still you can make a diagnosis of infective endocarditis. The patient presents with fever, cardiac failure due to the valvular damage. There can be cutaneous hemorrhage, maybe because of disseminated intravascular coagulation. Cutaneous hemorrhage can be there. Laboratory diagnosis. Any questions, doctor? This is one thing that is very important. Laboratory diagnosis. And I have simplified it and given infective endocarditis. Because of infection, you will have to do a culture and sensitivity. Blood culture and sensitivity, repeat it at least 3 times. If it is positive, fine. If it is negative, you have to repeat it again. Neutrophilic leukocytosis in the peripheral blood. ECG will be showing because of damage to the heart. Echocardiogram because of the damage to the myocardium or the endocardium or the valve, an echocardiogram. And when you take a scan of the body, there can be septic abscesses found in different parts of the body. It can be a brain, it can be an osteomyelitis, or it can be an abscess of the kidney. So it will be important that we do this. Culture and sensitivity, neutrophilic leukocytosis, ECG, echocardiogram, scan displaying the septic abscesses. The treatment, of course, is antibiotics and valvular replacement. It is easier said, but today these are the two methods by which we can tackle the major problem of infective endocarditis. Ευχαριστώ.